Okay, now we're gonna continue with esophagus. Esophagus, the topic that we're gonna discuss now is Barrett's. Okay. Now coming to Barrett's, we all know that it is a complication of long-standing GRD. If a patient is having a prolonged chronic GRD, then the patient can develop Barrett's esophagus. In Barrett's esophagus, what happens? There is specialized intestinal metaplasia. What is metaplasia? That एक तरीका के epithelium will be converted into some other type of epithelium. Here, the normal squamous epithelium is converted into columnar epithelium. कॉलमनर एपिथेलियम जो हम लोग के इंटेस्टाइन्स में होता है, ठीक है, इंटेस्टाइन्स में होता है. दैट्स व्हाई इट इज कॉल्ड अ इंटेस्टाइनल मेटाप्लेशिया. To diagnose a case of Barrett's, you need a endoscopic biopsy. And endoscopic biopsy से हम लोग जब histopathological examination करेंगे, what is the pathognomic feature in histopathological examination are the presence of goblet cells. Okay, these are very important, frequently asked, that goblet cells if present are pathognomic of Barrett's esophagus. And where do we usually take the biopsy from? It is usually taken from this red velvety parts of the esophagus. When we do an endoscopy, जहाँ जहाँ पे हम लोग को red velvety parts दिखते हैं, we take a biopsy from there. And as such, कि Barrett's अगर है, तो it can increase the risk of adenocarcinoma of the esophagus. Now Barrett's में there can be involvement of the long segments or short segments. Long segments are more than 3 centimeters, short segments are less than 3 centimeters, and these can be easily identified with the naked eye, right? We just go look through the endoscopic probe, and from these two, it is easy to take biopsy because these are visible from the naked eye. However, cardiac metaplasias, the other type of Barrett's, those are microscopic. Those are very tiny, which can't be visualized by the naked eye. Then, in those cases, we do a chromoendoscopy. What do we use in the chromoendoscopy? We use either methylene blue or lugol iodine. If the methylene blue is used, then the Barrett's and adenocarcinoma, those parts will be highlighted with the methylene blue, like in this picture. In lugol iodine, normal squamous epithelium will be highlighted. Okay. Now coming to the surveillance of patients who are already diagnosed of Barrett's esophagus. Here we have to have a high level of suspicion for dysplasia and adenocarcinoma. As we all know, अगर GRD है, GRD increases the risk of Barrett's. अगर Barrett's है, there increased risk of dysplasia and adenocarcinoma of esophagus. There's one protocol, Seattle protocol, which says there should be 2 yearly endoscopic surveillance and biopsy. And this is a small table. It's very easy to understand. Just go through it. These are the biopsy results and the next step of management. If there is no dysplasia, like in Barrett's, or there's only metaplasia, then we're gonna keep the surveillance endoscopy every two yearly. If there is indefinite for dysplasia, matlab there's nothing conclusive, ATP is there, but it is not diagnostic of either dysplasia or adenocarcinoma, then we need to treat esophagitis first and repeat endoscopy after 6 months. These three are very important and needs high level of surveillance. Low grade dysplasia, high grade dysplasia. If it is a low grade dysplasia, we're gonna do a endoscopic and biopsy every 6 monthly. For high grade, we're gonna do a 3 monthly. And in both those affected parts, we can treat with RFA. Okay. And if it is a adenocarcinoma, submucosal or deeper involvement, we're gonna go for esophagectomy. Okay.